Chapter 10 PowerPoint Part 1 Abnormalities of White Blood Cells. Introduction to white cell disorders. Alterations either to quantity or quality of a particular white cell. Increased quantity would have the suffix philia or osis. Decreased quantity would have the suffix penia. Quality would mean inclusions. Conditions of increase. Neutrophils would be increased in infection or inflammation responses, pregnancy, stress response, malignancies, surgery, physical conditions like heat, cold, or shock, or drugs. Eosinophils would be increased in skin diseases, parasitic diseases, transplant rejection, myeloproliferative disorders, asthma, and allergies. Basophils would be increased in myeloproliferative disorders, hypersensitivity reactions, ulcerative colitis, chronic inflammatory conditions, renal disease. Monocytes would be increased in chronic infections like tuberculosis, malignancies, leukemias with strong monocytic components, and bone marrow failure. Conditions of decrease. Neutrophils would be decreased due to drugs like chloramphenicol, chemotherapy, infectious disease, autoimmune diseases. Eosinophils would be decreased due to acute infections, adrenocorticotropic hormone, ACTH, or bone marrow aplasia. Basophils would be decreased in steroid treatment or inflammation. Monocytes would be decreased in autoimmune processes and hairy cell leukemia. Neutropenia. A neutrophil count lower than 2 × 10⁹, possibly the most significant finding of decreased cell lines. Causes are medications, bone marrow assault, like chemicals, viral infections, or splenic sequestration. Terms. Leukocytosis, an increase in white blood cells. Left shift. Bone marrow is responding to a need for more white blood cells by sending out younger cells, such as metamyelocytes and bands in peripheral blood. Leukemoid reaction, an exaggerated response to infection and inflammation in which the white cell count is between 20 and 50,000. No blasts are present. Leukoerythroblastosis, a significant feature of myeloproliferative disorder and refers to the presence of immature white blood cells, immature red cells, and platelet abnormalities. Stages of white blood cell phagocytosis. Chemotaxis. Neutrophils are attracted directly to the site of invasion through chemical signals stimulated by a foreign body. Interleukin-8 and complement help to guide the neutrophils to the site of infection. Opsonization. Neutrophilic attachment of invading foreign body only after foreign body has been opsonized or prepared to be ingested through interaction with the complement system or other immunoglobulins. Ingestion. Opsonized foreign body is ingested by the neutrophil. The foreign body is engulfed by the neutrophilic pseudopod membranes. Killing. Neutrophilic granules release their contents, which contain various lytic elements. pH of the cell is reduced. Hydrogen peroxide is produced. The neutrophil is also destroyed during this process. Qualitative changes. Toxic changes. Toxic granulation, toxic vacuolization, Dolly bodies. Nuclear abnormalities, hypersegmentation. Toxic changes. White blood cells increase. Increased neutrophils. Neutrophilia. Left shift. Toxic granulation. Toxic vacuolization. Dolly bodies. Toxic granulation. Normal granulation. Dust-like appearance. Toxic granulation. Excessive in amount and intensity of granules. Toxic vacuolization. Occurs in segmented neutrophils, Prolonged exposure to drugs like sulfonamides and chloroquine. Prolonged storage. Pseudo versus toxic vacuolization. Pseudo-intense vacuolization is caused in vitro when blood is stored for extended periods of time. Vacuoles are small and uniformly placed. In toxic vacuolization, freshly drawn specimens, 10% neutrophils vacuolated, caused by serious infection and prognostic indicator. Dolly bodies. Cytoplasmic inclusions that consist of ribosomal RNA. Rod-shaped, pale bluish-gray structure. Nuclear abnormalities. Hypersegmented neutrophils, have more than 5 lobes, megaloblastic processes, hereditary white blood cell disorders. May-Heglin anomaly, Alder's anomaly, Pelger-Hewitt anomaly, Chediak-Higashi syndrome. May-Heglin anomaly, an inherited disorder, thrombocytopenia and giant platelets. Abnormal bleeding may be present. Dolly bodies seen in the cytoplasm of neutrophils may appear in monocytes and lymphocytes. Alder's anomaly, Alder-Riley anomaly. Rare genetic disorder, coarse dark granules in neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Lipid depositions in the cytoplasm as a result of decreased mucopolysaccharide production. Pelger-Hewitt anomaly, fairly common inherited disorder. Hyposegmented nucleus is seen as peanut-shaped, dumbbell-shaped, or pince-nez-shaped. Homozygotes, spherical with no lobes and prominent nuclear clumping, could be confused with bands or metas. 70 to 95% hyposegmented neutrophils. Chediak-Higashi syndrome, rare autosomal disorder of neutrophilic granules. Giant purple-gray cytoplasmic granules. White blood cells are not fully functioning and show reduced chemotaxis and bacterial killing function. Symptoms: neutropenia, albinism, photophobia, recurrent infections like Staph aureus, poor platelet function, hepatosplenomegaly, liver failure, and abnormal bleeding times. White blood cell abnormalities, Part 2, Chapter 10. Reactive lymphocytosis. Show distinctly abnormal morphologies. Increased cell size, increased basophilia, and increased cytoplasm. Infectious mononucleosis. Viral illness, like Epstein-Barr virus or EBV, or human herpes virus 4. Found in saliva, spread by kissing, sharing food utensils, and drinking cups. 3 to 4 week incubation. Infects B lymphocytes. Symptoms are sore throat, fatigue, anorexia, fever, headache, enlarged lymph nodes, hepatosplenomegaly, autoimmune hemolytic anemia, increased liver enzymes. Diagnosis: rapid agglutination test, 10% negative. Slide smear, 10 to 60% reactive lymphocytes. HIV, causative agent of AIDS. Lymphocytes are primary target. CD4 and CD8 cells. Normally CD4 to CD8 2 to 1. Ratio reverses. Immune function completely fails. Opportunistic infections like pneumocystis gyrovecii, Mycobacterium avium, and Kaposi's sarcoma. Lymphocyte reactive changes. Extremely basophilic, clefting, and vacuolization. Lipid storage diseases. Gaucher's disease, pronounced Gaucher, inherited recessive. Deficiency of beta-glucosidase, which is the enzyme that breaks down the lipid glucocerebroside, resulting in accumulation of glucocerebrosides in the spleen, liver, bone marrow, and macrophages. Macrophage is unable to digest the stroma of ingested cells. The lipid accumulates in the cells. Gaucher cell is large macrophage with small, usually eccentric nucleus. Cytoplasm has crinkled appearance due to accumulation of glucocerebrosides. Cell found in bone marrow and lymphoid tissue. Clinical: splenomegaly, decreased liver function, bone pain, central nervous system involvement, may have short life expectancy. Niemann-Pick disease, rare autosomal recessive disease. Clinical: more commonly seen in Ashkenazi Jews. Clinical symptoms begin in infancy with poor physical development. Spleen and liver are greatly enlarged, often fatal by age 3. Causes: deficiency of sphingomyelinase, enzyme needed to break down lipids. Results in excessive sphingomyelin storage. Appearance: foamy cytoplasm, globular appearance, macrophages in lymph tissue and bone marrow. Leukopenia and thrombocytopenia may occur from increased sequestration from the enlarged spleen. Bacteria and other unexpected white blood cell changes. Bacteria: bacteremia or sepsis, gram-positive or negative bacteria or fungi, intracellularly, extracellularly. The rest is a lot of pictures that unfortunately wouldn't be very helpful for me to describe, so I'm going to skip on to platelet satellitism. In EDTA tube, patients develop IgG antibody that targets platelet glycoproteins. Ring around neutrophils. Falsely low platelet count. Collect platelet count in sodium citrate and multiply result by 1.11. Okay, I'm going to move on to the white blood cell abnormalities laboratory, which has some questions that I can go over here. Number 1 says, a slide is made from a specimen that is 2 days old and has been kept in the refrigerator. When the slide is viewed after staining, this image is seen. What is the most likely diagnosis and how should this be handled? The image shows pseudo-intense vacuolization, and it's suggested to recollect a fresh specimen. Pseudo-intense vacuolization looks like quite a few vacuoles throughout the cells. The cells on the slide are segmented neutrophils. Number 2 is, what toxic change is shown in this image? The image shows toxic granulation, which is quite a few granules throughout a couple of segmented neutrophils. Number 3, hypersegmentation is seen in megaloblastic processes. Number 5, which anomalies have coarse granules? Toxic granulation, Chediak-Higashi syndrome, and Alder's anomaly. The other 3 options are Pelger-Hewitt anomaly, toxic vacuolization, and May-Heglin anomaly, and they do not have coarse granules. Number 6, what is albinism? Albinism is partial or absence of pigment in the hair, skin, and eyes. Number 7, which word represents a decrease in a cell line? Lymphopenia. Number 8, what white blood cell abnormality is shown here? The picture shows several neutrophils and one other cell that I think is a monocyte that have large granules in them. And the answer is Chediak-Higashi syndrome, which large granules are a characteristic of. Number 9, neutropenia is defined as less than 2 × 10⁹ per liter. Number 10, which anomaly is shown in this image? The image shows 2 neutrophils that are both bilobed or dumbbell-shaped, which indicates a failure of the neutrophil to segment properly. The chromatin is coarsely clumped, and this is characteristic of Pelger-Hewitt anomaly.